Hi, welcome to PSY 745 Psychopathology. My name is Professor Elizabeth Juglick, and I'm going to be your guide as we explore diagnosis and classification as delineated in the Diagnostic and Statistical Manual. Today we're going to be talking about the evolution of the DSM-5 and how we can think about that in light of various cultural and ethnic differences. So why do we need a classification system for mental disorders? A very good question, and one that we're going to be exploring throughout this course. There are advantages to having a classification system for mental disorders. The first is that if you think of psychology as a science, the backbone of any science is to have a language to communicate in order to do research. So for example, if I say my patient has depression, that means something to you. You know approximately what symptoms that individual is experiencing. And a science can really only develop as far as it's able to classify the information in its field. A diagnosis can aid in communication. It can also then, as we conduct research, give us etiologies or causes. We can know about how to assess that disorder. We can know about the prognosis for somebody who has that disorder. And it also gives us various treatment options. However, not every system is flawless. It has disadvantages as well. And so when we use a diagnosis, we lose individual information or unique information about that individual. So for example, going back to my depression example, depression has 9 diagnostic symptoms, but you only need 5 in order to meet the diagnosis. So within those 9 symptoms, depression can look very different between people, thinking about various permutations and combinations. And even within that, when you think about appetite, you can have appetite gain or appetite loss. You can have too much sleep or too little sleep. And so people who have depression can still look very different from one another, even though they all have the same diagnosis. There's also the potential for abuse. A lot of high stakes decisions are made based on diagnosis. Not guilty by reason of mental disease or defect, for example, sexual violent predator designations for those who commit sexual abuse, institutionalizing individuals against their will. Diagnoses can be used to make all those high stakes decisions. And so if those are abused, those individuals can lose their rights. And then it also might be detrimental to client care. So if you ever take psychotherapy, you'll learn that the best way to do psychotherapy is to look at the individual, not as a diagnosis, but as a constellation of presenting problems. Where did they come from? What brought them here? What kind of things caused those problems? And so people might experience depression for a variety of different reasons. They may have a history of trauma. They may have lost a loved one. They might have come out of the blue. And based on the type of depression that they have, you might have different treatments. It might be, trauma treatment. It might be cognitive behavioral treatment, therapy. It could be medication treatment. And so we want to make sure that we're not losing those individual differences when we are, using diagnosis for treatment. So in the United States, we use the Diagnostic and Statistical Manual. Internationally, they use the ICD, which is used around the world, but given that you guys are working in the United States, the DSM is still the primary mode of diagnosis. And I've had many students ask me why we are studying the DSM and not the ICD. And it's a very good question, and one that potentially in the future will not be asked because we might switch to the ICD system as well. However, for the time being, the majority of you will be using the DSM in your work. And there's such significant overlap, and the latest versions of the DSM and the ICD worked to kind of have that overlap. So even if you learn the DSM, it will not be hard to switch over to the ICD at some point in the future. So one of the things that's really interesting about the DSM and mental diagnosis in general is how it's evolved over time. So this is not something that is a static process, it's a dynamic process, which also bears into question its validity. If you think about, we've really only had, diagnoses with the DSM for the last kind of 75-ish years. The first edition was published in 1952. And what's really interesting, if you look at the evolution over time, we're now in the 5th edition text revision, is that back in 1952, we started with a manual that had 132 pages and 128 diagnoses. And in 2022 with the DSM-5 TR, there's 1,050 pages and 541 diagnoses. So the diagnoses have almost quintupled, the number of pages almost by 10. So it makes you question, how real are these diagnoses and how do they vary so much over time? And that's what we'll talk about a little bit today. The DSM was first published in 1952 by the American Psychiatric Association. That's different than the American Psychological Association, as the American Psychiatric Association is part of the American Medical Association. They are physicians who are trained in psychiatry as opposed to us who are psychologists. It was developed from an earlier classification system that was developed in 1918 to meet the needs of the Federal Bureau of Census so that they could report on who is in psychiatric hospitals. Again, we needed to know who was there and how can we categorize these individuals. And the categorization systems were in use by the U.S. military in a survey of the views of 10% of the APA members. So they all contributed to the DSM-1. The initial manual, which you can see the picture on the right, had 130 pages and 106 categories of mental disorder. The next manual, the DSM-2, was published in '68 and had 182 disorders and was 134 pages long. So we're already increasing the number of disorders substantially from one version to the other. There were a lot of problems with the DSM-1 and 2, the first being that these manuals reflected the predominantly psychodynamic view of psychiatry, which was based on Freudian notions at the time. And those of you who are familiar with Freud and defense systems and mechanisms and ego, id, and superego, while those constructs are very interesting, they're very theoretical in nature and hard to kind of concretize. And so they were not very specific, and the inter-rater reliability between the diagnoses was not great. Furthermore, the definition between normality and abnormality was unclear. And this is also something that we're going to be talking about throughout this course, is what does it mean to be abnormal? And I think we're kind of coming full circle and really thinking about, is there really such a fine line between normality and abnormality? But at the time, it was really unclear who would meet a diagnostic criteria and who would not. What was an interesting study was Rosenhan in 1968 wrote a study called On Being Sane in Insane Places, kind of to highlight this distinction and really illustrate the subjectivity of diagnoses made with the DSM. He went into a psychiatric hospital in Pennsylvania and complained that he heard the words empty, thud, and hollow. He had no other symptoms, but was hospitalized immediately and diagnosed with schizophrenia. Over the next 3 years, he repeated the same experiment with 7 of his students and colleagues in 11 other hospitals. Individuals who reported the same symptoms were medicated and held in psychiatric hospitals anywhere between 8 and 52 days. Once they got hospitalized, they no longer reported any symptoms, but they were still maintained in hospital. He documented these works and argued that we had no really way of diagnosing mental illness. A research and teaching hospital then challenged Rosenhan after he published his work to repeat this experiment, and so they were kind of on the lookout for him. And so their staff were warned that at least one pseudo patient might attempt to get admitted. And during the time period that they thought somebody might come, 43% of patients were believed to be actors by at least one staff member. And what's interesting is that no actors were sent. And so it kind of highlights that we, at least at the time, and I think probably even today, are very poor at potentially, making determinations as to who has a mental illness and who does not. The biggest kind of change in the history of the DSM came in 1974 with the DSM-3. Robert Spitzer was selected as the chairman of the task force, and he kind of took a very different approach. He wanted to first kind of make sure that there was some consistency with the International Statistical Classification of Diseases and Related Health Problems. So that's the ICD that I was talking to you before, which is published by the World Health Organization. And it took on a far wider mandate. They really wanted to improve the reliability of psychiatric diagnoses, in part based on Rosenhan's kind of experiment, but also really wanted to establish specific objective criteria to facilitate mental health research, because until that period in time, research wasn't the way it is today. We didn't really know as much about different, mental health problems. It was still relatively taboo to have a mental health condition, and so we really didn't know a lot of it. They also developed the multi-axial system to attempt to yield a more complete picture of individuals and not just a simple diagnosis. So there were 5 axes, and this is actually how I learned when I studied from the DSM-4. This was then eliminated in the DSM-5. But what they did is they made committees of experts in the field, and so they consulted, people who were studying these things, who were experts in the field. They had committee meetings to discuss, each diagnostic category, and they wanted to be, kind of contrasting in the DSM-1 and 2, which was based on psychoanalytic theory. They really wanted to use more objective criteria, so signs, symptoms, and natural history rather than psychodynamic assumptions. And they really wanted to make a clear distinction between what was normal and what was abnormal. So what would be, what made somebody have a mental disorder and somebody not have a mental disorder. One of the controversies emerged was that there was a lot of Freudians around at the time, and the people who were psychoanalytic were not happy about kind of taking out things that were psychoanalytic in nature from the DSM, but the kind of the direction that the task force was going, they kind of viewed it as unscientific, and so there was a lot of political opposition at the time. It was actually in danger of not being adopted by the Board of Trustees unless the term neurosis was included in some capacity, and so they reached a compromise and they inserted the term neuroses in parentheses after the word disorder in some of the cases. The DSM-3 rapidly came into widespread international use. A lot of stakeholders used it, including insurance companies, which is a real game changer because you know that now people can only get insurance reimbursement for different treatments if they have a diagnosis. So that was like a real game changer. And it also kind of revolutionized the way that we practice mental health and do our research. The DSM-3 was really the foundation of our current version of the DSM. So this was like a huge revamp. Then in 1994, the DSM-4 was published, which now has 297 disorders and 886 pages. So I'm going to show you my age, and this is the version of the manual that I was trained on. This task force was chaired by Alan Francis. They had a steering committee, which is kind of the main committee of 27 people, including 4 psychologists for the first time. So primarily before this was, these were all psychiatrists before, but now we were including psychologists. And so they created 13 working groups with where individuals had specialization in the various different disorder groups. And each working group had between 5 and 16 members and 20 advisors. And it kind of continued the emphasis on empiricism. So we were looking to have good inter-rater reliability. We wanted to look at the research. And we wanted to make sure that what we presented was based on the research evidence. And the work groups conducted a 3-step process. So they first did extensive literature reviews on the diagnosis. They got data, including tests, from researchers who were researching these disorders out in the field, so they could better understand them, their etiology, their prevalence, different differential diagnosis. And then they conducted what are called field trials. And so they came up with their different criteria and had people use it in the field, meaning, people who are working with real clients, and they work to see, about the inter-rater reliability and get feedback from stakeholders. So that was a really, kind of more scientific way of doing things. They also included a clinical significance criteria to half the categories. And in order for somebody to be diagnosed, so even if you met all the diagnostic criteria, if it wasn't interfering or causing distress or interfering with your life in some way, you wouldn't necessarily meet you wouldn't have that diagnosis. So almost all the diagnoses required this clinical significance. So clinically significant distress or impairment in social, occupational, or other important areas of functioning. So people could have, could have the symptoms, but if they were still functioning well in all those other areas and they reported no distress or impairment, then they would not meet diagnostic criteria. They also added an appendix for cultural bound syndromes, listing mental illnesses or syndromes that are only recognizable in certain cultures. So this is the first time that we hear the mention of culture. And so this is an important step forward. And I think where the DSM has always been lacking is that we really failed. It's based on the Western model. We're failing to think about how culture, ethnicity, race, gender, sexuality, all those things kind of impact the way that people present symptoms. But the DSM-4 was not without problem. There was frequent comorbidity between disorders, which means that they weren't unique diagnostic entities, but there was really a lot of overlap. So does this mean that these are separate things, or is this more of a spectrum of, behaviors? Because you see a high degree of overlap between depression and anxiety. A lot of the personality disorders, people have multiple personality disorders. They also used NOS, which is not otherwise specified, and this was like a big kind of catch-all, or some people call it a garbage can. So if you have some symptoms but not all symptoms, people would often be given the NOS, like depression NOS, which has no diagnostic criteria. This was particularly problematic in forensic evaluations, where you would often see people with paraphilia NOS, where there would be some paraphilic behavior. But given the high stakes decisions that are made in the criminal justice system, having a diagnosis with no specific criteria is hugely problematic. There's also a lack of support for the categorical classification systems. Like, again, think of depression and anxiety. We all have, various levels of depression and anxiety. So at what point is the tipping scale? Like, it seems like a lot of these problems are present kind of on a continuum versus a category, and so we're kind of artificially making it categorical when potentially it should really be continuous. And so we know that generally dimensional models of abnormal behavior are better validated. 26% of all adults that were diagnosed using the DSM were given NOS diagnoses, which is hugely problematic. So then the DSM-5 was published in 2013. They started working on this back in '99, so it took a long time. They kind of got feedback on the strengths and weaknesses of the DSM-4 and wanted to address some of that. The task force consisted again of 28 members, including a chair and vice chair, and they had more diversity in the members, which was previously kind of neglected, both in terms of race and ethnicity and gender, but also in terms of professional affiliation, so more people from various different worlds outside of psychiatry. The DSM-5 was a modest alteration of the DSM-4. It was rumored that it was going to be continuous, but it also ultimately came out as a categorical classification system. But there is movement still to have that, and I think the DSM-6, if we ever get there, will be continuous, hopefully. And you'll note that they've moved from the Roman numerals to actually like actual numbers. So when you write DSM-5, you're actually writing out 5 instead of a Roman numeral. But there are criticisms of the process of the development of the DSM-5. Part of it was that the DSM history was too pharmaceutical. Most of the people up until the DSM-5 had links to the pharmaceutical industry, who benefited tremendously from people having diagnoses, because they could then prescribe medication for these diagnoses. So then in the DSM-5, they basically took out everybody who had links to the pharmaceutical industry. However, many of the major researchers in the field are funded by pharma at some level. And so people really felt like we were taking out some of the key researchers in the field because of this. So it's like, too much of one or too little of the other. It was too secretive because the APA enforced non-disclosure agreements. And so it really wasn't, they tried to make some of this open to the public. I'm not sure how much of, that feedback goes into the revisions. And it was too exclusive. So, previously it was only world-renowned scientists. And so we were taking out like a lot of the people who were in the field who were doing this work. And so the DSM-5 worked to be even better coordinated with the ICD-11. They pretty much overlap. It's been reorganized to reflect developmental perspectives, both across categories and within categories. So they kind of start with kind of childhood disorders and go to disorders that are more present later in life, but also within disorders, they go by ones that are present, earlier on in life. And it reflects dimensional approach to disorders, so kind of internalizing like the depressions to externalizing like the conduct disorders as well. And so, we talked about how the rest of the world uses the ICD and we use the DSM. And so we want it to be coordinated so that there's a lot more transparency, that we can do research across countries. It's still really controversial because if you look at the DSM, it costs a lot of money, as you know, because I made you buy it for this course, although it's something you will use repeatedly throughout your work. But the ICD is free and open resource. The DSM is primarily used for psychiatrists, and the ICD is for everybody. It's DSM is primarily used by the US and Canada as well, and it has a Western Anglophone perspective. The ICD is more global in the way it's used. The ICD is approved by the World Health Organization, where the DSM is approved by the APA. So you can see where we're going with this. I think in your lifetimes we will move to using the ICD. There are a lot of limitations with the DSM, but again, there's so much overlap that I think that it's important that you use what we are using here in the US, and if you want to learn the ICD or use the ICD in your work, you'll know that what you've learned can translate to that. As I mentioned, when I learned how to do diagnosis in the DSM-4, it was called a multi-axial system. That was dropped in the DSM-5. So in the DSM-4, I would have given, let's say, James Jones, axis 1 would have a diagnosis of major depression and alcohol dependence. So these would be the major mental health disorders. Axis 2 are the personality disorders and the cognitive disorders. So here he would have antisocial personality disorder. Axis 3 would be health conditions, so cirrhosis of the liver. 4 would be any social or occupational issues that needed to be addressed, which could be useful for therapy. And axis 5 was called a global assessment of functioning on a 1 to 100 scale, with 100 being you're functioning perfectly and 0 being you're not functioning at all. So it kind of gave you a range so you could see where that person was. It's not clear to me exactly why that was dropped, but this has now been dropped. So you can see in the DSM-5, you would not use an axis system. You would just give multiple diagnoses, and you can use the relationship problems as a V code, and there's no global assessment of functioning anymore. They also got rid of NOS, which kind of makes sense, but instead they use you're indicating the severity as mild, moderate, or severe, and there is now other specified or unspecified. In some of the research that we've done with diagnosis for sexual violent predator classifications, we basically have seen that clinicians are using other specified or unspecified as the new NOS. So they kind of took one problem and just made it a different problem. So the problem remains, like that other specified or unspecified is still being used, because if it's other specified, you're supposed to specify, and people often aren't doing that. They're just kind of using it as another way of saying NOS. So the DSM-5 is also not without criticism. It remains a product of historical precedent. It's more based on research data, but still, it hasn't changed dramatically since the DSM-4. It's very culturally specific. It's Western based. There continues to be a lot of scientific debate. For the paraphilias, there is tremendous amount of debate. Should hebephilia be in there? Should it not? Which paraphilia should be in? We only have 8, but there are technically, hundreds of paraphilias. And that we argue that DSM is empirically founded, could be overstated in general. As we talked about, there's not a lot of evidence for kind of a dichotomous versus a continuous distinction. And the distinction between disorders and between normality and abnormality has recently really, that debate has come to light, and it's kind of, we're kind of wondering, is this even a thing? Like, should we be labeling people as normal or abnormal? I mean, I think most of us have come to the conclusion that no, that's not helpful. We've even here at John Jay renamed our abnormal psychology class to psychological disorders and distress, to kind of take away from that stigma that's associated with abnormality. I think that does nothing but harm people. So there's a lot of problems still with the DSM, and I'm not saying the ICD has overcome this, because they have similar issues. However, I think diagnosis and classification in general is something that we are still grappling with as a profession, and we have a long way to go. So why kind of move to a dimensional approach as opposed to a categorical approach? I think it's better because you get a full range of severity, so we can see, like, you might have mild symptoms of anxiety, but they're still impacting your life. You might not meet diagnostic criteria, but that doesn't mean that you might not need some help, some coping skills. It completely can cover complete coverage of all areas of behavior. And so, rather than using the diagnoses, which can overshadow some other, problems, you can kind of talk about, the experiences the person has. And so people might have, depression and anxiety and some psychotic symptoms. And so we might be able to capture that all more broadly. There's evidence of improved validity using a dimensional approach. And so we really don't know. There's a lot of overlap with the underlying constructs. Like there might be the same genetic factors underlying a lot of these disorders. And for example, the genetic factors associated with depression and anxiety have been found to overlap completely. So why are we then making these two separate disorders? And the number of people who have depression who also have anxiety and vice versa is incredibly high. The two have a high comorbidity rate. So really, are these two separate disorders, or is this just kind of like they're a continuation of symptoms? The DSM also fails to take into account context. Like clearly if you're living in a war-torn zone, you're living in poverty, you have been oppressed, you're experiencing racism, all of those things are going to come to bear on the way that you're presenting. It's claimed that the use of a distress as additional criteria, so that, that specifier that was put in the DSM-4 solves the false positive problem, but that's not been found to be true. About half of all previous DSM authors have relationships with the pharmaceutical industry or drug companies. So were they somehow biased in their determination of disorders? Because the way that these disorders have evolved has been based on historical precedent. So we haven't gotten rid of disorders. And profit motives represent an increasingly medicalization of human nature. So you'll see, premenstrual dysphoric disorder in the DSM-5. So, should that be something that's pathologized? Is that a disorder? Because they now have medications for that. You've probably seen commercials for that on TV. But just remember that the DSM-5 is really a psychiatric textbook. It is not, doesn't mean that it is like the Bible per se. And so it gives directions. It can help you make diagnosis, but it's a living document. And I suspect in your lifetime, you're going to see many versions of this. It might even be abolished. Who knows what the future holds? In my lifetime, I've already seen the DSM-4, DSM-4-TR, DSM-5, DSM-5-TR. So, we'll see what's going to continue to happen. The DSM-6 is already in the works, and we'll see what's going to happen there. So one of the things that I think is really, really important, and a lot of your readings are going to reflect this week, is diversity culture in the DSM, because the DSM and diagnosis has been very influential, more for bad than for good in terms of the way that we perceive a lot of different issues in our society. But given the fact that it's a living document, it also has to accurately reflect what's going on in the culture. And as we change and as our culture becomes more diverse and people come from many different backgrounds and religions, ethnicities, genders, sexual orientations, I think we really need to examine what this means for diagnosis and how we can best serve our clients without causing harm. A great example was homosexuality. Homosexuality used to be a diagnostic criteria in the DSM, and it was only following protests from gay activists at the annual APA conventions in 74 to 73 that that the disorder no longer was included and listed as a diagnostic category. So when you think about the way we think about sexuality in general and the societal biases against those from who are not cisgendered or who are gay, that is significantly impacted by the way the DSM categorized that. And so it was finally by a vote of the APA trustees in 73 confirmed by the wider membership in 74 that homosexuality was replaced with sexual orientation disturbance. So that didn't mean that homosexuality per se was a disorder, but only if there was distress that resulted from people's sexual orientation. And so this was replaced with the diagnosis of ego-dystonic homosexuality in the DSM-3, and then removed in 87 with the release of the 3R. So finally, 87, so that was not too long ago that it was even kind of removed from the DSM. So as recently as the DSM-4, a category of sexual disorder not otherwise specified was included. And so this could include persistent and marked distress about one's sexual orientation. So if somebody was distressed by being gay, largely probably in part because society was making them distressed and they were not accepted, this could be a psychological disorder. So even though it was removed, technically, it was still there, and it still influenced the way society perceived and the way people were being diagnosed. Unfortunately, no such category exists in the DSM-5, but we still have gender dysphoria. So when people are unhappy with the gender that they are born with, they can be diagnosed as gender dysphoric. And so that's, again, pathologizing individuals who identify as being transgender. And so what does that mean, for the way that we perceive them? Again, we still have that distinction between normality and abnormality in the DSM. And so that can be largely problematic. If we think about gender diagnoses in the DSM, there's been a lot of evolution. So there was nothing in the DSM-1. In the DSM-2, there were sexual deviations, which was transvesticism. DSM-3, we have sexual disorders, which we had transsexualism and gender identity disorder of childhood. DSM-3R, disorders first evident in infancy, childhood, or adolescence. Transsexualism, gender identity disorder of childhood. Gender identity disorder of adolescence and adulthood. Non-transsexual type. So you can still see like people who are transgender or who dressed as the opposite sex were still pathologized. In DSM-4 and 4TR, sexual and gender identity disorders. So gender identity disorder in adolescents or adults, or gender identity disorder in children. So that's when their gender, their biological gender didn't match their identified gender, and they were having distress because of that. And so again, it's pathologizing, individuals who are transgender. This has now continued to gender dysphoria of adolescents or adults and children. And so I am hoping that as we move forward, we're going to see that this is going to continue to change as society evolves. And so we're not going to pathologize people and make people who, are not abnormal feel abnormal, because a lot of this has a lot of implications. And then there's been a lot of criticism, more broadly about kind of cultural influences and the DSM. As we've talked about, it's widely premised on Western models of psychopathology. And, we've really neglected issues of race and culture. So a lot of, when we talked about prevalence, there are different prevalences of disorders in various racial and ethnic groups, but because there wasn't a lot of research done across different races and ethnicities, we didn't have that data, and so that wasn't taken into account. And so, historically, we've seen a lot of underdiagnosis or overdiagnosis in certain groups of individuals. Groups that are historically marginalized or underrepresented were not reflected in the DSM. And so we know that clinicians tend to overdiagnose, underdiagnose, and misdiagnose clients from these groups, I think in part because they've largely been left out of the DSM. And, I think the biggest thing, and I think the thing that we're going to see, and I think that the continual model of mental health problems is going to be one solution for this is really the abnormal versus normal debate. Who is normal? Who is abnormal? You have depression, are you abnormal? You have anxiety, are you abnormal? You have schizophrenia, are you abnormal? There's a lot of stigma towards mental health, preventing people from getting help and treatment they need, the way people treat them in society, the way they're viewed as less than. And particularly we see that's more amongst already minoritized groups. And so the more that we make this dichotomy, it's like I am better than you, you are worse than me, I think is not helpful. And I think we need to kind of move away from that dichotomous diagnosis. The DSM has attempted to remedy this. It's somewhat of a patchwork solution, but they've outlined the cultural formulation, which calls for clinicians to assess the client's cultural background and reference groups when making diagnosis, possible cultural explanations of clients' issues, and cultural components that may impact client-counselor relationships. So this is the cultural formulation interview, which you'll find at the back of the DSM. It's a semi-structured interview that can help clinicians kind of obtain this additional information. This kind of helps, this flow chart is as part of the cultural formulation interview that helps you incorporate aspects of culture, religion, ethnicity. And when we talk about culture, we mean culture broadly defined. It doesn't mean just like, where in the world did you come from, but also what is your background, what is your sexual, gender, ethnic, socioeconomic status. I think all of those things are really important when making diagnoses, and you have to make sure that you're including them. They also include a number of cultural concepts or distress symptoms which are recognized within specific societies or cultures, and they're listed again at the back of the DSM. Again, these are not exhaustive, and these kind of have to be updated. And so in order, the DSM-5 worked further to kind of incorporate race, culture, and ethnicity into the DSM. So they developed 2 working groups, the Ethno-Racial Equity and Inclusion Working Group and the Cross-Cutting Cultural Review Group. And so they provided a comprehensive review and update of the impact of culture, race, and racism on diagnosis. So you'll see in the DSM-5 TR, there are more norms for racialized and ethnic minority groups in general, although they're still largely lacking. But this is kind of a statement that was made by the working group. We were highly committed to the use of language that challenged the view that race and genetics are the same thing. We used terms such as racialized and ethno-racial instead of racial to highlight that the construct of race is determined by cultural, social, legal, and political factors. We eliminated the use of terms such as minorities to classify races of people, since it relegates these races to inferior or lesser than status. And with respect to the US and the world, these races of people, typically referred to as minorities, are increasingly becoming the larger portion of the population. So again, going back to this as being a living, breathing document, I think we are going to see tremendous change as our culture changes, our society changes, our legal standards and politics change. And so you have to consider that when looking at diagnosis and giving diagnoses to your clients. In terms of what they updated in the TR, the prevalence data on specific ethno-racial groups, including when existing research documenting reliable estimates based on representative samples was available and not available. They also provided variations in symptom expression across racial and ethnic groups. They may provide cultural norms that may affect the level of perceived pathology. So people have different ways of reporting mental health and the way that it's perceived in different cultures. And then they also paid attention to the risk of misdiagnosis when evaluating individuals from socially oppressed or ethno-racial groups, which I think is really important, both being overdiagnosed and underdiagnosed. And so they kind of highlighted when that was the case. So now that you know the history of the DSM, which I think is really important to kind of know where we are now, I think this is a really kind of salient point, or kind of a question to leave you with, I guess, something to think about critically. Are classifications in psychopathology splendid fictions, compelling notions, or austere formulas devised to give coherence to their inherently imprecise subjects? So basically, are we making things up, or is this really something that is helpful, or is this something that we just still is a work in progress? And that was Theodore Milan back in 1991, and I don't know now if we are any better off. But I think it's important to know where we are coming from, to know where we need to go. And I know that you're all going to take all of this information and think about it critically and apply it to your patients to make sure that they're getting the best services that you know how to give them.